So now we're going to transition over to begin the kind of the technical portion of it. We'll lead in. I'd like to introduce again our keynote speaker today, and what I would describe as the mastermind behind all of the science. If you were here for the past day and a half, he was the MC for the science in the age of experience, where he had to cover the entirety of every problem the world is facing, and he did it with brilliant guidance and skill. But he's here today to share his vision of the virtual twin of the human, his experience that he's been doing, his vision, his hopes for his team, and his hopes for our community, what we can do, and how he can help. So without further ado, I'd like to invite to the stage Patrick Johnson, Senior Vice President of Corporate Research for Dassault Systèmes.
Thank you, Steve. Thank you, everybody. Well, it's a teamwork, everybody. So a couple of things that I wanted to share when kicking off this symposium. As Bernard showed, we strongly believe that twins can play a role, concrete role in a medical practice. The way we are investing is threefold. Of course, understanding how to model, represent, abstract the body, the organ, the physiological systems, the complexity, the interconnection between what makes us human. And that's the passion box. But also we are convinced that we want also to address and tackle the challenges of the care systems, the hospitals at large, because we believe twins can also revisit the way they are working. And I will not comment further on, but we all have ideas. And even if we elevate this at yet another scale, which is at the regional or even national level, how we can really represent the way our health system is working globally, from the economical standpoint and from the sanitarian standpoint. Of course, with the COVID wave, we understand that there are major topics, and it's not to be addressed in a silo way, economic on one side and sanitarian on the other side, but we believe twins, economical twins, nationwide twins can help there. And we did participate during wave 1 and wave 2 in several countries to basically propose cockpits of twins to conduct and navigate the crisis. There are white papers. Steve mentioned that. I invite you to consult this one because on a web site, you have a lot of use cases that we are investing on, and it's a call for action also for you to tell us what you consider is addressable. To us, Virtual Twin of Human, it's an engagement framework. We need you. We are considering ourselves as a catalyst. We cannot do everything by ourselves. We need your force, we need your expertise, we need your passion. And so what you see on the left side, it's a little bit our framework, if you will, our open framework, multi-scale and multi-discipline or multi-therapeutical areas or multi-organs, if you will. And I tend to see the living cell, the living gut, the living heart, the living brain, the living knee, and so forth, as little dots there that we are progressively connecting to have an overall comprehension, understanding of diseases, treatments, and life. And we have several bets. Of course, you could say, we're really far away from having a realistic representation of human body. As Bernard said, we don't want completeness, we want comprehension, even if it's plausible. But 40 years ago in aerospace, for example, when we had exactly the same message, lots of people were saying, you're far away of having something. And today it's obvious. And you know, in innovation it's always impossible, ridiculous, obvious. So we're walking that talk. And so the assumption is that pretty much like for manufacturing, wherein everything was relying on blueprints and drawings, we transformed the practices from pure document-based to data-driven, to modeling and holistic representation grounded. And so we elevated the practices from pure drawings to digital mock-up and now twins. And of course, I cannot resist but see an analogy with EHR, document-based, EMRs, and now multimodality with imaging and genomics. But on and on, what the virtual world is providing is a reunion, a gathering of all those modalities in an integrative model so that not only all the practitioners with their expertise sees the same thing, but they can agree on the route of action and next things to be done. And of course, associated with this new way of looking at things and looking at how to act, we are strongly believers that we should provide an environment for those practices, new medical practices to emerge, to be shared, to be evolved, to be transformed. And so this platform, healthcare-oriented platform, not only for the practitioner teams, but for the patient as well as a member of the team, actually. We believe that this platform is a key element in our roadmap, and this is why we are always interested to look at the challenges and how the practitioners and the professionals are facing them together. Because in fact, we don't do twins for the sake of twins. We do twins always related to a medical challenges, a medical issue, challenges that practitioners might have. So of course, Associated Living Heart and the Symposium has seen many examples. We have, for example, what Dr. Haagensen has been showing in terms of pre-operative planning. For the living brain, we use that, and you will see an example further on, for epileptic resistant patients so that we can anticipate what to do in the block. For the liver lung during the COVID times, it was used for devices to help patients breathe better. And I could go on and on with gut, with skin, with the living cell. And we don't do that only, I would say, in a pure structural way. I tend to see our twin as a multifaceted object. Is physiology, metabolism, structure, and system at once. And so we are always extremely interested, and this is the larger video that you see here, to understand life as a global system of systems interconnected between metabolism, physiology, energy consumption, because we are all made of equilibrium of proteins and organs. And so this is inevitable if we want to have a real serious apprehension and representation and abstraction of how the body is working. So a couple of examples to tell you where we stand today. And we saw an example even this morning. Of course, for example, for cardio, I will start with cardiology with 3 examples. We first started, thanks to Steve, using virtual twin for medical device manufacturers, so adjacent to our core industries. How could we improve medical device, not only design, but assessment in trial for certain population? And so this example is the example of cardiomyopathy, where the table is a little small, but in fact, for the past 20 years, there have been dozens of trials and proposals from the medical device industry to propose devices to address that pathology. But in fact, only 2 devices have been approved. Sorry, Steve. Only 2 devices have been approved so far. So what can we do for that? We saw this morning an example with one clip to clip approach. But in fact, there's so many things that we could be inspired from other industries, like something which is very natural for an engineer, design of experiment. What you see here on the bottom square with the green valves models, we have been doing design of experiment. So we have been varying all the parameters of this valve model. The valve size, the configuration, the speed at which it clips, the hemodynamic speed. And we have been creating a whole design of experiment so that in the end, if we can design or assess the effectiveness of a device related to that population, because in fact this is a population of valves, if you will, then we can help better move forward in a faster way and more efficient way for the approval in this specific cohort. Second example, not for medical device, for pharmaceutical and biotechs. And I always come back to that example. I'm sorry, Steve, and you know it by heart, but I love it so much because this is about additivity of twins. what we need to do, and this is a real challenge from a scientific standpoint, but my company has taken the bet that we are going to deliver this for the community, is not only to deliver twins for an organ at this place or a drug at this other place, but we want to provide the practice to couple those twins together, and not in a very difficult way, so that the magic appears when you put them together, something realistically is being measured. So what you see here is an analysis on cardiotoxicity for a drug. You have the living heart model, which has been modeled multi-scale. So different channels, ion channels, 11 channels, lots of cells, billions of cells, tissues level. And what we have been doing is coupling a drug, the effect of that drug on the ion channel, and of course, the pounding or let's say the normal or pathological behavior of the heart. And what is amazing to me, and you see some example depending on the pathology of the drug. No drug, 3 times the drug, 4 times the drug. Sometimes the observance goes completely wacko because the patient doesn't respect the observance. And what is very surprising, but it shows that we need to continue on this path, is that what is being simulated is an effect, torsade de pointe, which is known, and the measure from the simulation, from the virtual world, exactly match what is being observed in reality, at least for the low-level dosage. So additivity is key, because this is where we are going to really understand multidiscipline and multi-scale effect, and this is where we can explore the what-if and the virtual world to anticipate the best route of action moving forward. Another example, Dr. Genson, I could not resist, but of course, use your seminal work on the, I would say, personalized design of a device for a specific patient. I've shown this many times, so everybody knows. But I wanted to show the second example, because we want those tools not only to be used before, for example, the block, but also for an office consultation as a real-time vascular assessment. So let's run a video with sound.
Virtual twins can support healthcare professionals in the diagnosis, interventional planning, and follow-up of patients. Our virtual twin will focus on the cardiovascular system, and more specifically, on the body's major arteries. In order to make sure that the virtual twin is patient-specific, clinical measurement data is acquired, and a model of the arterial system can then be constructed. The arteries are modeled by a set of anatomical and physiological parameters, and the simulations will predict the blood pressure and flow rate everywhere in the system. And finally, the human arterial system is simplified to around 70 major arteries, modeled by 300 parameters. When a virtual patient's artery parameters are known, simulating the blood flow in their whole system usually takes several minutes. A faster prediction can be achieved by training a neural network on a dataset of synthetic population simulations. The structure of the neural network is inspired by the physiology of the arterial system, enabling it to capture its unique features. Thanks to that, the virtual twin can instantaneously predict the behavior of the whole arterial system and for any given patient. The virtual twin experience starts by assigning to each patient, depending on their demographics, an avatar that will be personalized with their available measurement data. The blood flow measurements in the selected arteries can be analyzed prior to the personalization. The calibration process relies on a second neural network that determines the best set of anatomical and physiological parameters given the patient's measurement data in a few arteries. Each blood vessel is now a reflection of the patient's real body features. The patient's blood pressure and flow rate are predicted with the real-time experience, and the results can be compared to the clinical data. Uncertainty quantification provides confidence levels for the virtual twin's prediction. The blood flow is immediately adjusted if the artery parameters are changed. The virtual twin can augment reality by giving us access to the blood flow even on unmeasurable arteries, therefore enhancing the practitioner's capabilities for diagnosis and interventional planning. The vascular twin can provide patient-specific boundary conditions for future full 3D simulations of any given part of the body, like the heart, lungs, or brain, or, for example, for specific major arteries. These boundary conditions at the proximal and distal locations of the artery are usually very hard to acquire in a non-intrusive way. Healthcare professionals like pediatric cardiothoracic surgeons sometimes need a heart simulation in a matter of days. This reduced order virtual twin can help accelerate the 3D simulations of the baby's heart. Another way to extend this virtual twin is by including the brain arteries and maybe even the venous system, leading us to a complete holistic twin of the cardiovascular system, with the hope that human virtual twins can one day save lives.
So what you've seen in this prototype is many things. Of course, there was AI, but as you've seen, we don't use AI in a black box way. We don't believe in that. There was a physiological driven, supervised AI engine. So there was physiological knowledge into the AI technology. And therefore, the technology that has been produced is exactly matching what a physiological cardiovascular system is to the level of knowledge today. And so we want to use that in real time. Transitioning to neuro. There you go. A couple of things to say. So you remember that even last year we presented this project on liver and brain, where basically we reconstruct personalized brain twins for epileptic patients that are drug resistant and for which there are none other exit than really an operation, resurrection. We have been moving forward. Right now, we have 85, I would say, twinned patients. So we have 85 patients that has been twinified, if you will, and for which the operation has been happening. It's part of a clinical trial right now. And we are also, and stay tuned, we will publish this, evolving not only for the electrophysiological diseases like epilepsy, but we are moving forward towards the neurodegenerative diseases with chemistry and, of course, the biology that is related in the synapses and the axons and the neurons. So stay tuned. We are addressing right now, starting to address with twin use cases, ALS and Alzheimer's as well. And finally, oncology. So you know that oncology is, we started with oncology at the very beginning. A dimension that is very key to us for oncology is the scalability of our twins. If you remember, for those of you who were there yesterday, the cell that you see in the middle is derived from Professor Weinberg MIT works. But of course, tumor is not this cell. It's 1 billion times this cell. And so in the platform that we are developing, that platform, if we're serious about biology and about medicine and about monitoring of diseases, should scale that level. It should scale 1 billion times to the cell. So what you see here is a stack up of those 1 billion times cell. And you see here this tumor development and behavior. We have injected here many behaviors in the model coming from the literature. Angiogenesis, lymphogenesis, mutation, motility, all those aspects that make basically a tumor. The scientific challenges today are how we correlate the virtual and the real, how we measure the real, which is still a challenge today. But I strongly believe that in the future, right now people are looking at genetic maps. in the future, people will be looking at virtual cancer cell and virtual tumor to try to anticipate their behavior. And this calls for a multimodal approach for this platform, not only multi-scale. There you go. And I want to show you what we have been doing with our friends of Medidata, because in the end, it's about, as I said in the very beginning, merging all the potential modalities there is to be able to better understand the situation. MRI on one side, CT on the other side, genomics on the third side, magneto on the last side. So let's see where we stand today, leveraging Medidata large imaging patrimony.
After a regular CT scan exam for low back pain, a patient is referred to a urologist for a first visit. This CT scan is performed with the injection of a contrast agent. The contrast agent is infused intravenously in the right arm and then propagates through the blood flow to the aorta, arteries, veins, and is eliminated in 5 minutes in the urines. Before meeting the patient, the urologist inspects the CT scan. The AI-enabled registration of different CT scans is a cornerstone technology to build a multimodal and multi-time point virtual twin. The 3 series can be merged to obtain a single series. The merged series is leveraged to generate a 3D virtual twin. As evidenced by scientific literature, this virtual twin has the potential to significantly reduce operative time while increasing patient satisfaction with physician communication. To differentiate cancerous from benign tumors or cysts, the most important marker is the enhancement of the lesion in reaction to the contrast agent. The computer-aided diagnosis model automatically segments each slice of the CT scan, allowing each pixel of the image belonging to the area of interest to be highlighted to the urologist. Moreover, the 3-panel view contains complementary medical information, such as the density value of the tissues of interest. This segmentation enables us to initiate the virtual twin of the patient, reproducing the patient's real anatomy through a virtual representation. To ensure the robustness of our proposed virtual twin, the automatic method is backed by a semi-automatic approach, allowing the comprehensive segmentation of all regions of interest and making sure none is missing. Once the segmentation of CT scan slices is completed, the reconstruction of a 3D representation of the patient's anatomy and of the regions of interest allows us to obtain the virtual twin. As a hybrid approach is adopted, compact segmented objects are represented by meshes, while diffuse segmented tissues, such as visceral fat, are directly highlighted in the merged volume rendering. Thanks to the virtual twin, the urologist is comforted in his kidney cancer diagnosis and can confirm it to the patient. He also relies on it to help the patient get a better grasp of her condition and to discuss the possible therapeutic options. During the next board meeting, the urologist discusses the patient's case. His explanation relies on the 3D virtual twin aggregating information from the 3 CT scan contrast phases. Now, thanks to the proposed virtual twin, the operating team shares a common 3D mental image of the tumor and of its peripheral area towards a successful completion of the
picture. No, wait, cut. Maybe I'm too long. So you understood the value of this. And I know, and Steve mentioned it, we are in this open framework, engagement framework, we are welcoming new friends for living kidney, living lung, living liver and stuff. And so we believe this can help. So we want to work with you guys. We believe that these board meetings, twin-based, 3D-based, collaboration 3D-based, are the next way forward. We truly believe that multimodality will become mono-twin modality as an overarching approach. And last but not least, to finish the talk, I cannot help but discuss also the synthetic control arm. And not only the synthetic control arm, but what I will call the non-3D twins. You've all heard, of course, because we've been having many keynotes already in the symposium on what we are able to achieve leveraging the massive data that we have from the clinical trials database from Medidata. We've just passed the 30,000 clinical trials with 9 million patients today. And so this, of course, allows us to generate a third arm, if you will, a third leg, which is a synthetic control arm, avoiding us to enroll and recruit people for just a placebo. I would even call that the Dassault leg, if you will. But this helps us also to envision something else. Because pretty much like in the design of experiments with the valve that we saw, we could try to correlate, model with those synthetic patients from the synthetic arm. And therefore, we can envision a mixing between twins in the organ fashion, twins from the medical data approach, opening maybe the path for a synthetic experimental arm. Who would have thought of that? And so this is also the reason why I showed you the torsade de pointe, because if you show the design of experiment, the torsade de pointe and the synthetic control arm, these merging together, then this opens a brand new perspective. So to finish, again, this is a call for action. It will take us time, but we are convinced that it's an exponential pace with you guys. We are launching worldwide. We're starting in Europe, but this is going to be worldwide, a massive program, and living heart, living brain, living lung are parts of that. Basically to address many medical use cases, many medical challenges, and in order to deliver this healthcare platform I was talking about in the very beginning. We also want, with Steve, to propose you some sort of an open compendium for medical twins, medical organs, medical practices being simulated or experienceable, because we believe adoption, education, dissemination will be key factor, key transformation factor to have a smooth, progressive transition from the state of medical art today to twin-based next generation medical art. And so Dassault Systèmes is here to catalyze, to work with you, and so I thank you very much for that.
Thanks, Patrick. Fantastic. Well, I'd love to have the time for you. I know you have a million questions for Patrick, but as I said, my job is to keep us on time. And so we're going to move on. Hopefully that gave you a lot to think about, see how your piece of work fits into a bigger picture, and find Patrick later and fire your questions.